Hi everyone, this is Dr. Connell and we're in week 8 of the term, and the final topic that I want to touch on is quality of care. Certainly something we've discussed at points along the way, but if you go back to the graphic syllabus for the course, kind of the premise of how I've walked you through the topics is that we need to measure health. We kind of start there, but our ultimate goal in doing that measurement is to improve quality, to have the optimum outcomes. And those steps in between are the dynamics that are involved in continuing to improve the quality of care. It kind of leads us to looping back to continuous measurement. So we see that the efforts of technology and other market changes are yielding better outcomes for us. So let's just talk a bit about some of the key concepts. This presentation or this PowerPoint is posted in the folder, so I may not linger on each slide, but between this and your textbook, I think you get a good idea of the concepts involved. So what is quality of care? What does that mean? And if you take this list, well, here's a definition from the Institute of Medicine. It's the degree to which services for whether it's groups of individuals or larger populations increase desired health outcomes and do that in ways that are consistent with professional knowledge. And for the DNP students and others, and that's that whole movement. It's 23 years later of moving and enhancing evidence-based practice. Now, Don Berwick, who had been the founder of the Institute for Healthcare Improvement, and I believe he's back there now, and more recently the head of Medicare and Medicaid, his point when he started into this field was every system is perfectly designed to achieve the results it gets. So when you look at an outcome that's unsatisfactory or problems, you have to look internally and look at yourself to see, well, all right, how did we create that? How do we change that? There are so many aspects to quality of care that keeping a focus on all of them can be very challenging. But this, in the perfect world, is what you want to achieve. You want it to be safe. You want it to be effective, efficient, good outcomes. You want improvement over time. You'd rather prevent than treat. You'd like continuity. We know that access to care is so essential. And you want to deliver care in a way that's respectful and caring, and it needs to be affordable. Just how do you do all of that? This is not an effort that's just within our healthcare system. It is worldwide, and the World Health Organization, which, keep in mind, deals with healthcare systems at all levels, from the barely developing to the very well developed countries. But they laid out a framework of how to get to these goals. And the main one is that you want optimal health for all. And this means attaining better health levels and reducing inequality to the extent that you can. And that inequality can come, as we've discussed, through access, through cost, and again, through the quality of the care you get. You want a system that's responsive so that you can meet not just the health needs, say the treatment needs, but you want to deal with the issues we talked about in the patient's perspective of respect, cultural awareness, orientation, customer service, and having that be definitely considered part of achieving quality. They stress fairness in financing, and this has been a problem in our healthcare system that we're aware of and are moving forward on with the reform that's coming. But the idea is that your contribution to the system should not impoverish you. Wouldn't we be wonderful when we get to the point where there aren't bankruptcies for healthcare? And that you pay a proportion of your income so that we have a progressive approach to financing. Now, one model that I believe is in the textbook, what I think is useful, because it's very straightforward, is Don Abedian's framework for quality of care. And he started this in 1980, and refined it a bit over the time, but you might hear this one is this, you have three qualities, three concepts: structure, process, and outcome. Now, structure are the settings, the size of the hospital, the design of the patient room, how medication is dispensed, a variety of structural components, many of them fixed, many of them challenging to change. Process is what you do. It's the various steps, the more fluid piece of it, might be one way to look at it. And outcome is the impact. And if you kind of take a challenge or a problem and look at it from, or break it down from these three components, it's helpful in finding out, well, where's the issue and where's what we need to fix. Here are some examples of structure. I think I mentioned some. The number of nurses per hospital bed, physicians per capita, number of CT scanners, the number of home health care agencies or capacity, the number of nursing homes. And I would also go into the design of some of these facilities and how some of our hospitals are quite old and they've been adapted, but how much of what is the challenge in maintaining quality and safety is part of the structure. Then there's process, things like giving a beta blocker, following an MBI. So this kind of becoming standard practice. Is the process done? Immunizations are a process. Outcomes are survival at a minimum, hopefully. Improving your functional status, patient satisfaction. Now, hold on a second. So where is it best to monitor this quality? So we have these three. Now, structure, here we could talk about it being necessary but not sufficient. I think part of the challenge is it's the most difficult to change. You can't retrofit everything. We would see pictures over the years of new technology coming, and it doesn't fit in the patient room. So stuff sits in the hallway and it's wheeled into the room. Whereas a hospital built newly today would have a lot more things designed right into the room, right into monitors. They would have learned how design can be improved to improve safety and outcomes. So part of that structure is as necessary but not sufficient. I guess you could work around it, but it does contribute quite a bit if it's just something that's out of date and you're having to fight against it to get things done. Process is where, from my point of view, it gets the most attention because it's what we do and it's the things that are more easily measured and quantified. How many times did we give those beta blockers after the MA? Did we give it 100%? If we say, oh, we gave it 70%, well, how do we get it to 80 or 90%? So it is more natural and it's almost the starting place many times to look at the process. The only challenge there is sometimes the process is a reflection of the structure of trying to work around something that is making it difficult. So that's why these three indicators are useful to look at as a whole. And the outcome is what is the outcome, and is it related to the care? Again, tied to structure, tied both to process, tied to other elements possibly outside of the control. Now, the predictors of outcomes are treatment of effectiveness. There's an element of chance. There are basic risk factors built in. So part of moving forward in this way is how you measure outcomes. And there are increasing ways, I believe it's touched on earlier in the textbook, about trying to bring in the quality of life into measuring outcomes and get those qualities and dailies, which are trying to assess not just your that you survive, but what's the quality of that life? How many more years did you live? Or if your life was lost in a process, how many quality years were lost? And dailies are disability years lost. So moving towards measures, trying to capture that as well. Now, this being a quite significant movement towards improving patient safety and quality of care was kind of really kick-started in 1999 when the Institute of Medicine brought out To Err is Human. I would say it didn't gone kick-started. I mean, it really kick-started because the statistics in it were shocking. And they are still shocking, even though, what's it, 14 years later. But it placed quality on the national agenda. It was where it brought out that 98, I think the number was 98,000 Americans died every year from a medical error. And that number was staggering. Now, even 14 years later, the number is still quite high. And you'd say, why, and why is it taking so long? Well, it took a period of analysis to understand why that was happening. It's not that, it's like turning an ocean liner around. It's not something that happens quickly. You had to change, you had to look at structure and say, are things designed well? Look at processes. And what you really needed to do was develop enough data to look at where the errors were and why they were happening. So this report was probably the first, and there are several, I think, on a coming slide, of reports that were put out that started quantifying and putting reasons behind this and pushing our system towards more systematic care, more integration, more evidence-based. Well, next slide. Here are some of the subsequent reports from the IOM on quality, crossing the quality chasm, keeping patients safe, patient safety. So these are evolving over the years, but it's still got quite a bit of attention on it. So progress made, a ways to go. Now, the IOM laid out kind of 6 aims for improvement. So safe, yes. Avoid unintended patient harm, evidence basis. This is where you start in these 14 years of saying we've got to focus on the patient, their needs, medical needs and other types of needs, their rights as a patient, and more involvement in the process. We have to look at timing of things, that many of the quality issues and safety issues were delays or barriers to care. How do we do that? Need to be more efficient. There's quite a bit of waste of resources and time and staff. And we're aware that there's not always equity in the system. So they map these out as aims to work around, to give it some format. Part of that is also to focus on cultural change. We have gone through that in this course of saying we cannot just change some aspects. We have to look at changing how things are developed. Now, in this instance, in a way, cultural change meant kind of internal within a healthcare system. Cultural competency, yes, that's part of it, but it was really a mind change, a cultural shift within healthcare systems that you need to do things differently. The move towards accountability. Medicare, again, the development of data that allows you to compare providers, to have providers report events, report certain data that is now, and again, 14 years later, we're starting to see that emerge where you have enough of a database to have valid comparisons and ways for payers and patients and consumers to compare providers and other components of the healthcare system, which was not an option many years ago. Now, what we've also learned in the class is that linkage between payment and quality. Where you put the money is an incentive. And so we are moving away from fee-for-service and putting the financial incentives in places where they will drive change and drive different approaches. And we, again, can only do that well if we have the metrics, if we have enough data and measures, so that we can tie payment to something that's pretty solid. And that's the progress, and that is what has enabled accountable care organizations to now have some validity going forward. There's been a trend beyond the reports of the IOM. There have been movements within Medicare to start first by making payments contingent on submitting the data. That started in 2005, kind of standard now. But again, think of the change it took for an organization. If it wasn't collecting the right information, it had to validate it, make sure it was accurate, and had to submit it. Next step was to tie bonus payments to it. So again, more gradual, one step at a time, tying incentives to submitting the data. Part of that was, if you have a system that's not very automated, and I think we all hopefully appreciate at this point that healthcare lags behind other business and industry sectors on the use of IT, banking, Amazon, online purchases, so much that's just so far ahead, and healthcare lagged behind. So government put incentives to in getting systems. They're very expensive, very challenging to have for an organization to do. But without it, you can't continue the acquisition of information. You can't continue on a paper-based system. So we needed to move towards that. Other steps are transparency of pricing information. And we're not there yet. You see articles even in the news, I think just a couple of weeks ago, about what hospitals charge and how over the map it is, and how rather crazy, insane our pricing approach is. So that is movement underway, but that one's taking a little bit longer. Now, another step towards putting, as it says, teeth into quality movement was comparative effectiveness research, and this is the goal of having new drugs or new technology or even new techniques, new surgical techniques or other things that are going to be adopted that you just don't need to say, demonstrate that they're safe for the patient and then they're effective, that they have the effect that you say they will. You know, they lower blood pressure, they work on cholesterol. You have to show how they compare to other modalities that are out there. Is this drug better? And so this is started in 2009 and certainly enhanced in the Affordable Care Act. And ultimately, this led to the most recent, in 2010, almost 3 years ago, where the Affordable Care Act was passed. And many of these things got more teeth and are moving forward. So great progress, I must say. There's been quite an effort. It's not as quick as we would like, though we might see more momentum now that kind of the framework, the basics of metrics and data collection are there. That's a huge step. But we still have no true national goal-setting progress. We still have kind of fragmented approaches. You could argue we don't have enough measures. We have too many measures. Are we going about this in a way that makes sense? So we still are grappling with that. Process versus outcomes, back to Donna Bedian. How do we make sure that we measure process? That's in some ways the easier one to grasp and measure, but making sure we're also capturing the relationship between the process and the outcome. Methodology. If you've got anything that's a comparative thing like health grades or hospital compare, you're going to have well, especially if someone doesn't like their rating, there are going to be challenges on the methodology. So having a consensus on that, again, is a challenge, but progress is made. We then, within all this, have special populations, mental health, veterans, children with special needs, and the others that I don't know that they're getting the immediate attention, but they, again, are going to have their own issues looked at. And of course, we always have unintended consequences of most anything we do and try to figure out how to work with those. Competency and high performance measures. Just again, improving care. That to me is just pushing the bar a little higher each time. Now, what's also gone on is that you have the industry change, and we talk about evidence-based guidelines coming more common. And for our MBA and OL students, the students that we have in the Doctor of Nursing practice, they are training to be clinicians who bring evidence-based practice into the clinical setting. They are really going to be on the scenes trying to bring this, not trying, they will be bringing this forward into the setting. So this is a very major shift, and we will be seeing the benefit of it in the coming years. What's also happened within the healthcare industry side of things is there's been an adaptation of some of the quality improvement models used in other industries. Six Sigma, for example, I think our business MBA folks should know this one, about that, it's really that the error rate, whether it's in manufacturing or supply chain or other things, has to be, just down to the third standard deviation or whatever Six Sigma is. And that's what's tolerated. And we see that imposed, and those goals have to be met. And that quality improvement, say, just in the development of cars over the last few decades, is significant. But in products and whatever is very clear quality improvement models. And it's like, well, why can't they work in healthcare? And in many places they can. And large hospital systems have kind of been the first to do that. And to start looking, maybe first they look at the technology of making sure lab results are always accurate or medical testing is always accurate. But over time that can move on to other processes. The improved data collection, again, will just enhance the ability and the reporting system. So the main industry change I would point out is adapting these models. The employer's not sitting by either. The employer has been probably bearing as much of the brunt as they're willing on seeing double-digit insurance premiums, maybe almost every year going up that much, and pushing back and saying this is not acceptable, and looking at ways to improve that. Some have been to push some of the cost onto the employee to pay more of their premium, but employers have also put more effort into keeping their employees well, say with wellness plans, and saying one way we can manage healthcare costs is to prevent you getting sick, keep you healthier. And it has made economic sense to them to provide incentives to do that. Some could be just wellness programs, prevention, having a gym on site, things like that. By involving the consumer or the employee in what things cost, they want that individual to be more aware of the cost, maybe shop around a little bit, look at the health grades and the comparison data, and choose accordingly. And there are other employer-based entities that are looking at gathering quality data and assessing it. There are business coalitions. I think in the Bay Area there's the Pacific Business Group. We have Leapfrog, who go out there and they collect this performance data and they analyze it, and they tell the employers, this health plan that you've got 2 or 3 health plans for your employees, this one does better here, this one's doing this, whatever. Again, being proactive in this situation. They are a player. The providers, well, they're in a way reacting to this, and but they are seeing changes and adapting as it comes along. Not always easily. There is huge variation still in outcomes on getting evidence-based care. There's also a real lag in something that's shown through the evidence as being effective and the optimal choice, but it can take up to 17 years, a staggering number, for something that's got demonstrated value to be picked up and made standard care. Why is that? And that's something that has gotten a lot of attention and got to bring that down. If something comes in and is shown to work and shown maybe to have better outcomes and provide access and whatever, why should it take even 5, 10 years to diffuse into our system? It needs to be looked at. So all of that is another ongoing effort. The stakeholders are many, touched on some. IOM, Medicare, big driver, Leapfrog, the Institute for Healthcare Improvement. Compliance-driven is part of what's happening. If you're asked to report data and you're measured against others, that's kind of leaving providers a little reactive. And it means that you meet standards. It doesn't necessarily mean that you've got the buy-in of those providers because they feel it's kind of been imposed on them rather than something that they are part of. So you want to have many efforts. I think leadership and administration of healthcare organizations, especially large ones, their challenge now and down the road is to be a leader and to really engage in these systems as they change, because we know a lot of change is coming. And again, back to wanting patient-centered care. We want the patient proactive. We want them engaged with their clinician. You can't have the clinician ready to be active and engaged without the patient. So learning how to do this in a time where there are a variety of cultural differences and patient information is limited, and the things that we've touched on in the last couple of weeks, you're now aware of the process and what it takes to move forward on this in this area. So ultimately, you need those cultural capabilities, whether it's the internal culture of the organization or also the cultural capabilities, the competency with patients. You need technical capabilities. The one most getting attention here is IT and data collection. Those of you who are in the Kaiser system or one that's more integrated have maybe experienced how they are touching on you at all points along the way. Your care is increasingly integrated. And those two within the organization are needed to improve excellence in patient-centered care. So part of that cultural capability is aligning the vision and the mission and the strategic plan of the organization, having a board that's engaged, having clinicians engaged and not resisting change. That will take some transparency and excellent leaders going forward. So if you are in the career track of being a leader in healthcare, there will be a need, tremendous need for effective leaders. Technical, you need all of the things that are in process, clinical protocols, physician order entry, all the data systems that are essential to really making this work. So again, complex. You may find yourself in an organization looking at this or whatever evolves as an organizing platform to assure quality of care. And ultimately, we want to see the patient at the center of care. We want the patient to have a medical home, a point of coordination that integrates care and optimizes. And essentially, I think as the technology improves and these systems improve, we'll have the ability to customize care much more to each patient, but also start to see it be somewhat seamless and move away from the fragmentation that is our system and improve in time as best we can. So thank you very much on sharing this talk about quality.